Xiaojin is the chief physician of the Department of Cardiology at FUWAI Hospital, and she is also the committee member of Women's Health Group in the Cardiovascular branch of the Chinese Society of Cardiology, and Professor Guo is a very experienced interventionist as well. So the topic from Professor Gao is gender difference in coronary heart disease. Please, Professor Gao.
Thank you. Good evening, everyone. Thank you, Professor Sun. Thank you for a kind introduction. And thanks for the invitation from the Asian Heart Society Cardiovascular Prevention Council. It's really my honor to be here for this presentation. Okay, let me share my slide. Okay, the topic I want to communicate with you today is gender differences in coronary artery disease. As is known, coronary artery disease remains the leading cause of death in men and women, but there's a sex-related differences in the epidemiology, pathophysiology, clinical presentation, diagnostic testing, and management of CAD between women and men. And in general, CAD in women remains understudied and recognized and diagnosed and treated globally. The prevalence of coronary artery disease is higher for men than women, and increases with age. The average of age for the first myocardial infection in women is 22 years compared to 65 to 0.6 years of men. But it is estimated that within 1 year after first myocardial infection, 23% of women and 18% of men will die. And the 5-year mortality of women is 47%, and of men is 36%. So I would like to focus on the risk factors, physiological characteristics, diagnosis, and the treatment of CAD in women. The first part is risk factors. In fact, men and women share similar modifiable traditional cardiac risk factors for CAD, such as smoking, hypertension, diabetes, and so on. And these 9 risk factors accounted for 90% of population attributable risk in men and 94% in women. And this is from the InterHeart study. It revealed the association of risk factors with acute myocardial infection in men and women after adjustment for age, sex, and region. Similar odds ratios were recorded for the association of acute myocardial infection with smoking and abdominal obesity, psychosocial factors, and fruit and vegetable consumption, and raised lipids. But the increased risk associated with diabetes and hypertension, and the protective effect of exercise and alcohol seemed to be greater in women than in men. Additionally, women are at risk caused by female-specific risk-enhancing factors, such as early menopause, inflammatory diseases, pregnancy complications, and so on. The next part is pathophysiology. This figure shows the mechanisms and characteristics of myocardial ischemia in women and men. I think women and men differ in the differential diagnosis, lesion and vessel characteristics, and triggering factors. Atherosclerotic plaque rupture is the primary mechanism responsible for myocardial infarction in men, but the plaque erosion is the major cause of coronary thrombosis, particularly in perimenopausal women. And the inoca and the coronary microvascular dysfunction is more common in women, and the obstructive coronary artery disease is more common in men. And the mental stress, emotion stress, and psychosocial stress are common trigger factors in women, but the physical stress is the main trigger factors in men. And then the gender differences between perimenopausal women and men may be largely related to the estrogen-dependent effects, and whereas the menopausal women are largely protected from coronary artery disease, estrogen loss following the menopause leads to a rapid clustering of risk factors such as hypertension and diabetes. But the obstructive CAD may not develop in women until 20 years after the menopause. And then let's move to diagnosis. I think that our diagnosis for CAD mainly relies on the patient's symptoms and the diagnostic testing. Women were less often reported typical symptoms like chest pain and diaphoresis than men. Women, it's okay. Women are more likely to present with more than 3 associated symptoms. For example, epigastric symptom, palpitations and pain or discomfort in the jaw, neck, arms, between the shoulders, legs, and so on. These atypical symptoms in women contributes to delays in seeking care, diagnosis, and delivery of appropriate treatment strategies, resulting in worse outcomes. And the table lists the utilization and limitation and the sensitivity and the specificity of all the diagnostic testings. The exercise treadmill test is most common used screening method for CAD, but the false positive rate is higher in women than in men. And the coronary artery calcium scoring is one of the most powerful predictors of subclinical atherosclerosis. It can be used to risk stratification. Yeah. And the temporary strategies for patients presenting with typical or atypical symptoms, the abnormal electrocardiogram and raised serum troponin presume a diagnosis of acute myocardial infarction. But for female patients, complete diagnostic evaluation should include workup for vasospasm, microvascular dysfunction, and coronary embolism. The differential diagnosis includes non-significant CAD such as plaque erosion, arrhythmias, coronary vasospasm, spontaneous coronary artery dissection, arterial cardiomyopathy, and myocarditis. And the recommendations and the treatments has gender differences in the CAD. Sorry. The sex specific differences and accommodations in guideline. Current ACC, AHA, and European Society of Cardiology guidelines for the treatment of ischemic heart disease offer a recommendation that, in general, are not different between men and women, but have added a descriptive section on sex-based differences. The 2013 ACC/AHA ST segment elevation myocardial guidelines highlight that 30% of patients presenting with STEMI are women, and they remained undertreated despite the universal recommendations for treatment. Based on NCDR action registry data, women had a longer door to fibrinolysis and door to balloon times. The 2014 HACC guidelines for a non-ST segment evaluation ACS offers a strong recommendation for an early invasive strategy in women with high-risk features. For pregnancy patients, revascularization is reasonable if the ischemia guided strategy is ineffective especially in managing life-threatening complications. And the 2012 ACC/AHA guideline for stable ischemic heart disease and the 2014 focus update war against estrogen therapy in postmenopausal women is class 3 and level of evidence A, no benefit. Because no clinical trials have shown a reduction in cardiovascular risk or improved clinical outcomes from hormone therapy. And the 2011 ACC/AHA guidelines for CABG noted that most recommendations for CABG in women are extrapolated from studies that predominantly studied men. Studies of women receiving CABG demonstrate higher periprocedural mortality and morbidity. The risk factors management for secondary prevention of CAD was generally worse in women than in men. And there remains an implementation gap with women have lower rates of assessment, education, and treatment of primary and secondary prevention. And the of note, the women have a 1.5 to 1.7-fold greater incidence of adverse drug reaction than men, partly due to a smaller distribution volume and a lower clearance. It's the same. And pregnancy women is very special. Both maternal and fetal considerations should affect the choice of therapy. But for high-risk pregnant patients with STEMI or NSTS, urgent PCI should be considered, but the radiation dose should be reduced as much as possible. And unfortunately, only limited information is available regarding the safety of many drugs when used in pregnancy. And the low-dose aspirin is relatively safe, but there's a lack of evidence of the benefit of P2H12 receptor inhibitors. The last part is problems and outlook. I think there is obviously a persistent knowledge gap with regard to optimal risk stratification and management in female coronary artery disease patients. There's a prominent patient and system delays in women with CAD, and maybe because of the limited awareness of for the latent CAD risk, maybe a lack of sex-specific thresholds with the clinical guidelines or the limited performance of the diagnostic approaches. But all of these limitations are the result of a persistent underrepresentation of women in cardiovascular studies. I think all of them hope these problems could be changed in the future. And it is crucial to secure appropriate representation of both sexes in clinical trials and studies. And the risk prediction tools that are tailored to women should be further developed and consider the difference of traditional and emerging risk factors. And the society guidelines must increase awareness of sex-related differences in CAD outcomes with explicit tailored guidelines for women. The reduction of disparities in clinical outcomes requires sex-specific strategies to tackle the problem in the diagnosis, treatment, and prevention of coronary artery disease in women. And the effort of various campaigns and initiatives to create awareness about heart disease in women must be continued. Actually, improving the diagnosis and treatment of female patients with coronary artery disease, I think is is extremely challenging, and this must and I think there is much